So Donggu is a senior SPR here in cardiology, and will present the case that we are going to see.
Just a quick summary of the patient here from the ward who came in a few days ago. Background of hypertension, 52-year-old gentleman with a background of hypertension which was found incidentally after a motorbike accident earlier this year, for which he's taking ramipril and amlodipine. And he's very fit and active normally, does smoke up until now, but the only other risk factor is his father had suffered with 2 heart attacks in the past. So he presented with chest pain, which started when he was at the gym. He goes to the gym very regularly, and he noticed some ache and feeling not quite right. And on his way home, this got worse and worse. By the time he got home, he was complaining of very severe pain that was going down the right arm, and he started vomiting. And straight away, he knew what was going on because it looked very similar to what had happened to his father. And his fiance called an ambulance. He came through to our primary angioplasty service at Hammersmith Hospital, and went straight to the cath lab, and I've just got some selected images from that. So started off looking at the ECG, by the way, so an inferior STEMI. So we started looking at the left coronary artery system, and as you can see there is some atheroma in the circumflex artery, and got some more views, but nothing flow limiting. And there's also some atheroma in the LAD, which is thought not to be flow limiting, particularly with the inferior STEMI on the ECG. So looking at the right coronary artery, the culprit territory, so there's a very proximal occlusion of the right coronary artery. So they put the BMW wire down, and then they actually, we haven't got the live images of it, but they used a Hunter catheter to aspirate clot from the vessel, and you can see that there's a very severe proximal lesion, quite a tortuous vessel. And this was pre-dilated, and then they put in a Resolute stent, which was 3.5 by 22 millimeters, and they then post-dilated multiple times actually, and they used IVUS guidance to actually they put up a 5 millimeter balloon to very high pressure, and made sure that they were truly opposed. And this was the final result, so a very good result from primary angioplasty. So he has had an echocardiogram on the ward, but we'll start here and go through.
Thank you, Jason. Now maybe let me introduce you the patient. Neville is here. He's looking at his pictures. Can you tell the people how did you feel when you came in? Just so you can use my...
When I came into the hospital, I was in quite a lot of discomfort and pain, quite scared, to be honest. I kind of knew what was happening to me because I'd experienced this with my dad. I'd seen my dad have 2 quite major heart attacks. I was a lot younger, so I was aware of what was happening to me. The first medics that came to see me were very calming for me. They kept me calm, they told me what was going on, they kept me informed of everything that was going on. When I got to the hospital, it was the same, the doctors and that were fantastic. Everybody was assuring me that I was going to be okay, and that after this procedure, which was going to take 20 to 40 minutes, that I'd feel fine, and that's how it was. And today I feel like I'm back to normal really, and really thankful for what they've done for me, and I'm really happy to be here. If this helps anybody today, then I'm happy to be here today.
Thank you very much. Excellent. So let's do some of the imaging without contrast first. David will start getting some pictures. It is interactive, so at any point you can interact and ask anything you want to know about the patient. David, the imaging, the right ventricle, the left ventricle. Yes.
Was there any right ventricular dysfunction at presentation?
Well, I haven't seen the echo. That's the first echo I see. So let's look at the right ventricular function. Okay. So from the long axis, the 1/3, 2/3 was preserved. The RV, there was a question earlier on, how do we fit the RV into the sector? So you notice that David is modifying a little bit the four-chamber view to focus more on the right ventricle. There it is. So that is a simple, gentle movement, a few degrees, focusing on the RV. Free wall, septum. The RV seems to be of pretty normal. Actually, it is surprisingly rare for to have right ventricular dysfunction, even in such a proximal RCA occlusion. And the LV, well, any comments about the LV function? Well, how you would comment on the LV function? No, doesn't matter. Take the microphone. That is obviously the three-chamber view. You can dial up the view you want to see, and David will bring that. That is a two-chamber view, yeah? Inferior wall, septum. Anything that strikes you? There are some...
Reflex is normal.
Okay, well, take the microphone. Help your colleague.
It has a cinetic and not that, the two-chamber, please. While the inferior wall has on the base segment, it's asymmetric.
Yeah.
Yes, it's there.
There is a regional echinacea. Okay? If you are not convinced, anyone who is not convinced? Everyone is convinced.
What about the anterior wall, the mid and apical segments? Are they entirely moving normal?
The apical apex.
Mid-apical anterior segments.
Up there.
Chamber, yeah.
Okay, the apex is one of the biggest problems in echocardiography to see properly. You are quite right to ask the question. And if we are not seeing the apex well enough, despite focusing appropriately, do you see all these subtle movements and optimization of the image that David is doing? Okay, so...
quite a good indication for contrast anyway.
Well, yeah, I was coming to that, yes. If there are people not convinced about the apex, including yourself, then contrast. And, okay, we haven't chosen the patient by quality of the echo. As I said, he hasn't had a study yet, so this is the first comprehensive echocardiographic study. And, yes, okay, so we have one question to answer about the apex. Pretty much everyone was convinced about the basal, inferior basal echinacea, right? So any other questions that remain? We have probably resolved. Let's, one other question that remains. Yeah.
Mid to apical anterior wall is hyperkinetic.
Louder?
The mid to apical anterior wall. Slightly hyperkinetic.
Mid to anterior wall.
Anterior wall, I think it's like the second. Wide band.
Anterior apex. Okay, yeah, okay, that's a reasonable question. We did not resolve, and we will use contrast to image the apex and the anterior wall better. There is one last question that we would like to answer for this particular patient. So we have the MI, raised troponin, we have inferior echinacea, and we have full revascularization. Right? What do we want to know?
Yeah, just one question. Would you relate this short segment of echinacea to his clinical presentation? Because he has a proximal RCA, I would expect if he has echinacea or hypokinesia, it will involve
More
extensive. Do you have to check it on short axis?
Yes, we can check short axis, but it's not uncommon to have only regional inferior basal and mid-inferior echinacea, whether it is proximal, mid, or distal. There is one question that we would like to answer, is whether there is restored perfusion in this infarcted area. Because you can argue, yes, we have opened up the artery, as we saw, very nice angiographic view, but what about perfusion in this segment? Right? That's a reasonable question. Now, how long ago was the revascularization?
48 hours.
48 hours ago. So we would expect in 48 hours to have restored perfusion. And this is the new thing that the contrast Mark was saying earlier on. So yes, we can see better the function, but can we see actually restoration of myocardial perfusion in this infarcted myocardium? Right? Okay.
There we go.
Let's get on.
So we start with an apical foreshadowing view. So what we're going to do first of all is we'll turn on contrast-specific imaging modality. So this is, now you notice that the image goes quite dark when we do this because in fact what the software is doing in the machine is it's trying to suppress the tissue. So it's trying to suppress the tissue so we'll see the contrast selectively. So we'll start the contrast running now. In a few seconds you'll see it coming into the right ventricle.
Up here.
Watch. Here it comes. Well, that's pacifying the right heart. And we're doing this with a pump, so and then you saw a few seconds later it's coming into the left ventricle. So we're going to leave it for a while in this LVO mode, which is not particularly designed to look at myocardial perfusion, but it gives you a higher frame rate and allows you to look more at the endocardium. So if we're looking at left ventricular function.
If you see the mechanical index on top right here, it is going up to 34.34.
0.24.
Oh, sorry, 0.24.
And you can see a little bit of swirling at the apex. If I just put the pointer on, you can see at the apex there's a bit of swirling. That's actually some contrast destruction occurring there. So we could actually afford to increase the contrast rate a little bit because we're getting into some destruction. If you put it up too high, you might get some attenuation. We're running at 0.6 of the millimeter. I'm just going to increase it up to 0.7. Just increase it a little bit so we get a little bit more. And what we usually do is tailor it so we don't get too much attenuation. So if you put too much contrast in, you'll get a shadow forming down here at the basal segments. But what we want to try and do is reduce the amount of destruction at the apex there. So, actually like to stall that, David, and then we'll go and look at two-chamber view. Okay, and we'll go into two-chamber view now.
Okay. So this trio wall, that's the area of interest.
I don't know about you, Petros. Actually, I think that anterior wall looks pretty good to me.
Yeah, so the question to the gentleman there in the middle, what do you think about the apex and the anterior wall now?
Yeah, it looks normal now. Yeah.
Okay, so contrast point made.
So there we go. We'll go to three-chamber view.
By the way, it does not work in the department.
Okay.
Yeah.
That's good. So why don't we have a look at some parasternal views? Now, his parasternal window is quite good. Now these tend to be a little bit more challenging because you've got the contrast in the right ventricle here, right at the left, so this can cause a lot of shadowing of the left ventricle. And so sometimes it's a bit more difficult. But you can see, so we've got reasonable views here.
Mark, what do you think about this outflow here?
Yeah, it looks like it might be a little bit dilated actually. A bit big, I agree.
This is something that without the contrast we were not able to identify, but now I think it is.
Yeah, so looking at a short axis view, it's if you can get a short axis view, the right ventricular outflow tract. You can do that, I'm not doing. Cylinders are difficult. And there's a short axis view there. So I think what we might do is we might change the way in which we're doing the imaging. So as I said, this is LVO mode now, and I want you to look at the mechanical index up here, which is 0.19. So that's the measure of the output power. So what we can do now is change this into a low MI mode, which is going to be even lower,